Good afternoon, ladies and gentlemen. It is a pleasure to have you join us today for a very special presentation. We have the great honor of having Dr. Ahmad Jardat from Ahmad, Jordan, to be able to present to you today non-invasive breast brachytherapy, AccuBoost, a novel conformal therapy. With that, just a brief background on Dr. Jardat. He is a very well-recognized key opinion leader throughout the world in brachytherapy, but had received his medical training at the Moscow Röntgen Radiological Institute and did his fellowship at the prestigious William Beaumont Hospital. He enjoys a number of important roles, including consulting radiation oncologist, head of gynecology cancer service, director of the brachytherapy program, and an expert in ocular plaque therapy at King Hussein Cancer Center. He is a consulting radiation oncologist with the International Atomic Energy Agency, and as a key opinion leader throughout the Mideast and around the world, he enjoys many speaking engagements. Before we have Dr. Jardat begin, just a few notes. Your microphones will be muted during the presentation, but at the end of the presentation, there will be a Q&A session to answer any questions that may arise during the presentation. During the presentation, if you do have a question you would like to pose, you can simply use the chat function on your control screen, and we will pose these questions to Dr. Jardat at the completion of the lecture. This presentation will be available on our AccuBoost website and will be forwarded to all of those attendees. But if you do have specific questions, please email Mike Mooney at AccuBoost.com. You see the address here. So without further ado, I'd like to introduce Dr. Ahmad Jardat with great pride and pleasure. Thank you very much. Dr. Jardat?
Thank you, Mr. Chairman, for the nice introduction. Today, my talk will be about the use of the AccuBoost in the treatment of early stage breast cancer. So, radiotherapy in its two forms, external beam and brachytherapy, plays an essential role in the management of breast cancer, especially after breast-conserving surgery. In the recent years, accelerated partial breast irradiation has been widely used to treat early stage breast cancer. Different techniques of brachytherapy are available for accelerated partial breast irradiation, which include interstitial implants, intracavitary devices with single, multi-lumen balloons, and intraoperative radiotherapy, and finally, non-invasive image-guided brachytherapy, simply known as AccuBoost. So, my talk will be about the use of the AccuBoost. What is the AccuBoost? It is a non-invasive mammography image-based guided breast brachytherapy utilizing high-dose brachytherapy after loader. What are the benefits of the AccuBoost? Why we need to use it? It is a non-invasive radiation delivery in a simple outpatient procedure, so it is a very convenient to the patient. The accurate dose targeting due to daily real-time imaging before each fraction of radiation, so it is an adaptive radiotherapy. Regarding skin sparing, lower skin doses and a result lower skin complication. Regarding the toxicity, less toxicity and as a result, better cosmetic effect. Regarding healthy tissue sparing, radiation is delivered parallel to the chest wall, so it will minimize the exposure to the underlying tissue and organ, such as the heart and the lung, in addition to the skin sparing. Regarding conformality, it is a conformal radiation because the field matches the target size, the shape, and the location. So regarding the method and technique of the AccuBoost, before starting the procedure, we have to appropriately select the patient for this procedure. It is very crucial and important because in order to achieve the ipsilateral tumor recurrences rate that are non-inferior to the whole breast radiation. So for patient selection, there are several guidelines that have been developed, such as ESTRO, Update ESTRO, and Update American Brachytherapy Society guidelines. Here you will see the updated ABS criteria for the accelerated partial breast radiation, which include the age not less than 45 years, tumor size not more than 3 cm, the histology, all invasive subtypes, and DCIS regarding estrogen receptor may be positive and may be negative. The surgical margin negative, so no tumor on ink for invasive, but not less than 2 mm for DCIS. Lymphovascular invasion is absent and the nodal status is negative. So the breast is immobilized using a moderate compression. The breast will be between compression plates. And the benefit of this compression include breast immobilization, so good fixation, no motion, and according to that, no ITV included in the target. Decrease the breast separation, and as a result, reduction of skin dose. In addition, it will displace non-target breast tissue out of the radiation field, and a result decrease irradiated volume. The digital mammography provides a localization of the target volume. There are a series of the custom applicator with different sizes, range from 4 to 8 cm in diameter, and they are designed to deliver a highly collimated beam using high dose rate remote afterloader. And the applicator and mounted on the mammography paddles centers on the target to deliver high dose rate iridium 192 along a box technique to orthogonal axis, craniocaudal mediolateral. And the tumor bed must be visible on mammogram, on the mammogram. And the planning target volume, so the PTV, must be less than or equal to 8 cm, and the breast must be compressible to a breast separation less than or equal to 7 cm. Here you will see the non-invasive image-guided breast brachytherapy system, which include the breast immobilization, pair of a plate in the mammography machine, the image guidance KV X-ray tube and cassette, targeting grid, collimator photon imaging using series of applicator, and finally, the HDR unit. So, how we prepare the patient or simulate the patient for the AccuBoost treatment? Gentle immobilization. It will keep the breast in place. So, it will eliminate chest wall motion, so no ITV margin is needed. Minimizing setup uncertainty, so the PTV is very small and even no PTV. And finally, this will displace non-target breast tissue outside the radiation field. So the elegance of simplicity, it is a single platform with multiple functions. So the immobilization will help us in displace the normal healthy tissue from the radiation field. In addition, it will eliminate the respiratory motion. It will eliminate the motion of the breath. And finally, it will give us the confidence in target coverage. So we need very, very tight margin. Regarding the imagings, usually we obtain two images. The first image from the craniocaudal, and the second image is medial lateral. So in this image, the radiation oncologist will review these images and he can identify the target from real-time mammography images. And regarding the irradiation, you will see the radiation will be delivered through the craniocaudal and the medial lateral direction. So it looks like a box technique. So the therapeutic dose will be very high in the overlapping area where the center of the target, while minimizing in the peripheral where is the skin, normal skin. So the how AccuBoost work or the treatment process overview. The imaging in the craniocaudal, and then the treatment also in the craniocaudal. The next step is the imaging in the medial lateral and the treatment also in the medial. So we will have the box technique. How we do determine the radiation target. Traditionally, for a booster dose of radiation, we usually use the SCAR as a guide. We usually use the pre-treatment or parameters such as CT, ultrasound, palpation. So all these will guide us to determine the target. In addition, if there is eclipse in the operative bed, it will be very helpful. So this raises the question, is eclipse a good surrogate for localization of the target or identified the lumpectomy wall? The question is, many investigators are happy with that, and they are agreed that it is good for target delineation. But it is an ideal. The simple answer is not. So we have to standardize the location or the placement of these clips. So if we have standardized, we have to have a good collaboration with the surgeon. So good collaboration between the radiation oncologist and the surgeon will give us a good standardization of the placement of these clips. So the ideal of target delineation is to use both surgical clips and the pre-operative and post-operative change. So this is the optimal. So how the radiation oncologists select the applicator and determine the target. The selection of the applicator is depend on the size of the target. So we, based on these surgical clips, the radiation oncologist determined the target, and then we added 1 centimeter uniformly around this target to create the applicator size. So which factors that influence the eligibility for a breast boost using the non-invasive image-guided breast brachytherapy? This study was done by Dr. Yoslav and Professor David, and they found that 72% of evaluable cases are eligible for the AccuBoost. And the reason for the eligibility was as follows: patient discomfort with compression, inability to locate tumor bed, very posterior tumor location, small breast size. So about 28% were ineligible. So our aim, how to solve this problem to increase the number of patients that were eligible to the AccuBoost brachytherapy. A multiple study were done for the use of the AccuBoost. And the first study, the initial prospective NIBB accelerated partial breast irradiation trial that talk about the rationale, technique, and visibility of partial breast irradiation using a non-invasive image-guided brachytherapy. And this prospective phase 2 trial was run through the Brown University Oncology Research Group and led by Dr. David and Yaroslav Hibel. So the dose of radiation was 34 gray in 10 fraction using high dose rate source iridium 192. And the dose was delivered to the CTV and PTV, which include the lumpectomy cavity with a uniform 1 centimeter margin. And the treatment was either daily or twice daily based on the patient preference. This is the preliminary result regarding the acute skin reaction. No skin reaction or grade 1 in 8 patients, grade 1 in 28 patients, grade 2 in 11 patients. No patient developed grade 3 skin reaction or most discrimination. The rate of grade 2 acute skin reaction was associated with the applicator type and the breast separation. And the conclusion of this trial, NIBB is a visible and well-tolerated treatment, and NIBB hold promise as an alternative method to deliver accelerated partial breast irradiation. The outcome of the study with a median follow-up over 3 years showed the following. The ipsilateral breast tumor recurrences was 2.5%, 1 failure remote from target volume, no regional or distant recurrence, 3 patients developed new contralateral breast primary, no grade 3 or higher late toxicity, subcutaneous fibrosis grade 3, 0, excellent and good cosmetic was 97.5%. The next study, NIBB ABPI fastest trial, is a 5 fraction accelerated partial breast irradiation, was conducted based on the result of the previous study. And the rationale for the use of the study is the majority of patients elected for once daily treatment. The patient don't like twice daily. It's convenient for the patient to go for once daily treatment. However, this result in treatment delivered over 3 weeks. So it's not good or not ideal to the patient in regard to the convenience. So the NIBB AB fast trial uses 5 fractions once daily, and the dose was 28.5 gray compared with 34 in 10 fraction in the previous study. So the early result of this, the fast trial, 40 patients were evaluated. The acute skin reaction, grade 0 to 1 in 28 patients, grade 2 in 11, grade 3 in 1 patient. No recurrences, no grade 2 or greater late toxicity. Regarding the cosmetic outcome, good in 7.5%, excellent in 92.5%. Regarding the predictors of the acute radiation dermatitis, you will see here with the increased mean breast separation with compression, you will see that the radiation dermatitis grade 2 or higher is more. So after the mean breast separation of more than 6 centimeters will have 25% of grade 2 dermatitis. When the separation is more than 7 up to 8, it will be 43. And when the separation is more than 8 centimeters, it will be 100. Regarding the application size and the prediction of the acute dermatitis, you will see here that after 6 centimeters of the application size, the rate of dermatitis will be very high. In 7 centimeter size, it will be about 50%, and in 8 centimeter application size, it will be 100. So this risk factor will be main breast separation is 1 centimeter and application size is more than 6 centimeters. So the conclusion of this, the first trial, treatment well tolerated, toxicity mild, few patients with a grade 2 to 3. Follow-up is needed to assess if this will translate into late skin toxicity. Skin toxicity associated with the treatment volume and separation may be avoided by limiting 5 fraction approach to the patient with a smaller target, so 6 centimeters or less the applicator size, and the separation of the breast equal to or less than 7 centimeters. So the early outcome of late toxicity, cosmesis, and local control are good. The next, the APPI study is the APPI data registry. It is a multi-institutional register study of accelerated partial breast irradiation using non-invasive image-guided breast brachytherapy. The aim of this study is to evaluate the visibility, safety, and efficacy of the NIBB across various settings, and it allows a collection of data on a large number of patients treated across different institutions and different settings. So 2 registers now are available, and all AccuBoost users are encouraged to participate in the Boost and in the APPI registry. Currently, there are more than 200 patients were evaluated, and the result showed the following. The accelerator partial breast irradiation delivered using NIBB is well tolerated with a low rate of significant acute toxicity. Late toxicity and cosmetic outcome are also favorable. Longer follow-up is needed to confirm late endpoint. And finally, I would like to say that in the near future, I hope that Jordan will be joined the AccuBoost user and will be joined the AB cancer registry. Thank you very much.
Hello, everyone. My name is Ray Burkalt. I'm with Advanced Radiation Therapy, and I want to thank you for your attendance today. We will wait a few moments to collect questions from the audience, and then we'll pose them to Dr. Jardat. Feel free to use either the chat pane or in just a few moments, feel free to open your microphone and to ask the questions live. So let's just take a couple minutes to allow the questions to come in, and then we will begin. Okay, we do have questions now coming in. Dr. Jardat, the first question we have from the audience, can you tell us, is the patient treated while sitting down or standing? Ladies and gentlemen, I'm sorry, we seem to have lost Dr. Jardat for the moment. We have also with us the CEO of Advanced Radiation Therapy, Piran Sioshansi. Dr. Sioshansi, would you be able to respond to that question?
Yes, patients are typically given a choice to get the treatment either standing up or while they're sitting down. So it works in both modalities.
Okay, thank you. I have several other questions I hope you can answer as we wait Dr. Jardat to return. Next question is, what is the dose given?
So as Dr. Jardat described, patients are given a choice between 10 fractions or 5 fractions. If you deliver 10 fractions, you have a choice of delivering it twice a day, 6 hours apart, or once a day for 10 days. For the 10 fraction treatment, the daily dose is 280 centigrade, 280 centigrade times 10. For a 5 fraction treatment, the daily dose is 570 gray times 5.
Okay, thank you. Next question. What are the challenges of implementing these techniques in a developing country like Jordan?
I think NIBB, non-invasive breast brachytherapy, is particularly well suited for developing economies of the world. It relies on HDR brachytherapy, and it's a turnkey system where, independent of any other modality, a patient can be treated with a conformal dose with real-time image guidance, and it relies on very modest requirements of HDR.
Very good. Next question. Can you use a cobalt source for brachytherapy in doing this technique?
The answer is yes. It's equally applicable to iridium or cobalt. The preference for iridium is that iridium source is at 10 curies. Typically, it's delivered, the source is delivered at 10 curies. And therefore, it takes a shorter time for treatment as opposed to cobalt, which is a 2 curie source. But as far as the technique is concerned, it's equally applicable to iridium and or cobalt.
Thank you. Next question. Can you comment on the skin dose, as this is a brachytherapy technology? How is it possible the skin dose is controlled?
I'm glad you asked the question, because this goes to the heart of the technology. As you notice in the presentation, you use 4 vectors on 2 different axes to treat the tumor bed. And therefore, by definition, this entrance dose is a fraction of therapeutic dose. So even though it's a little counterintuitive, even though you're using brachytherapy going through the skin dose is always at a fraction of therapeutic dose. And this is why you see such a small skin toxicity and skin reaction and good cosmetic outcome.
Next question. What treatment planning system is used?
The treatment planning for AccuBoost is very simple. It relies on a spreadsheet, a nomogram, where 4 factors, actually 3 factors, determine the treatment time. When breast is immobilized, the separation of the paddle, the size of the applicator, which relates to the size of the lesion, and the source activity. Those three variables contribute to the dwell time for the source. So it's typically a nomogram based. It takes 2 or 3 minutes while the breast is immobilized to feed in the number of dwell positions and have someone else check to make sure that the selection is correct and patient is readily treated. So it's nomogram based. It takes a couple of 2-3 minutes to do the entire treatment planning.
Okay, next question. What percentage of patients are eligible, and is it different for Boost versus APBI?
We have noticed that in places where they use this technique, anywhere from 2/3 of the patients, that is 66%, to 88 or 90% of patients are eligible for the treatment. It's used equally for boost to the tumor bed and or accelerated partial breast irradiation. Incidentally, we find in the COVID-19 era, where patients are reluctant to go to hospital for extended daily treatment, that AccuBoost is finding great acceptance for APBI, 5 or 10 fraction APBI treatment.
Next question. Which HDR systems is AccuBoost compatible with?
AccuBoost works equally well with Elekta and or Varian equipment. It has been tested with both systems and it works just fine. Including the newer models of Eckert Ziegler, they work equally well.
Very good. Next question. How long is the treatment?
The treatment time, of course, depends on whether you're delivering boost dose or APBI. And when it comes to APBI, it also depends on whether you're delivering 10 fraction or 5 fraction treatment. A typical time for a patient treatment, defined as when the patient walks into the clinic to the time she walks out of the clinic, based on the publication in the field, is 17 minutes, plus or minus 7. It's plus 7 when the lesion is large, when the breast is a large breast, and when the source activity is near the end of its life. And it's 17 minutes minus 7 when it's a smaller lesion, smaller breast, and source activity is near full 10 curies. I must tell you that the treatment time, the beam time could be as little as 4 minutes. But ordinarily, we suggest that you should allow half an hour, give or take a few minutes for treatment per patient.
Okay, next question. Can you explain or quantify the amount of discomfort of the patient, as this is a mammography technology?
Very good question. Mammography is a painful experience. With AccuBoost, there's really no need to compress the breast. You apply enough pressure to immobilize the breast. You ask the patient, are you feeling any discomfort? And the minute the patient says, I'm beginning to feel the pain, you back off and you tell her not to move. Because based on the image you take, you're going to position the applicators and treat the breast. But there's no point of making the experience painful for the patients. So typically use 1/3 of the pressure involved. In mammography, you ask the patient for onset of discomfort, and you back off and you rely on patients not moving during the treatment.
Thank you.
I must tell you that patients have been asked to rate discomfort on a scale of 1 to 10. It's typically 1. And they've been asked to score boredom. On a scale of 1 to 10, it's usually 7. You leave the patient alone in the room. They complain about boredom, but not pain.
Very good. Next question. How long does commissioning take, and can you explain what is involved?
Commissioning takes very little time. The instruction on how to accept the equipment is provided. You want to make sure that the dose that you claim that you deliver is in fact what is delivered in every case. And it involves setting up a phantom arrangement, making sure that the applicators are perfectly lined up. And usually you measure the dose to the central location and make sure that this is exactly as anticipated.
Okay, thank you. Next question. Have you used the AccuBoost with an Eckert and Ziegler BEBIG brachytherapy unit?
I know it's been evaluated on BEBIG equipment. Whether it has actually been used for the treatment or not, I can't say with certainty.
Very good, thank you. At this moment, we have no further questions. Ladies and gentlemen, if you have any last minute requests, please type them in now, or we'll move forward and wrap up the session today. So certainly on behalf of Jardat, Dr. Jardat, who unfortunately wasn't able to continue, and for all of us at Advanced Radiation Therapy, I wanted to thank you for your time this morning and this evening, depending on where in the world you are. I will note that this presentation will be made available online on the AccuBoost website, www.accuboost.com, and we will share the responses to these questions as well for you to be able to share with colleagues. So with that, again, I want to thank you all for your time and wish you a wonderful day. Have a good day.